Welcome to the Explainer. Today, we're doing something a little different. We are going to simulate a high-stakes, consultant-level general surgery oral exam, the kind of thing that makes your palms sweat. I'll be playing both the examiner and the candidate as we walk through a classic critical case, acute limb ischemia. Ready? Let's begin. All right, candidate, you get the call. You're needed in the ER stat. There's a 65-year-old man who says his right leg suddenly started hurting, and it's severe. The clock is officially ticking. Tell me, how do you proceed?
Okay, thank you. So, my first thought here is that time is critical. I'd head straight to the patient to make a rapid assessment, but while I'm doing that, I'm also getting some essential things started to stabilize him. We need IV access and to get him on a monitor right away. Look, the absolute #1 priority is to stop this from getting any worse. So, I would immediately start the patient on intravenous heparin. That's going to help prevent the clot from getting any bigger. At the same time, we're starting IV fluids, and I'd ask for a Foley catheter to be put in. Why? Because I need to keep a really close eye on his urine output. It's a great window into how his whole system is doing. We'll also send off some baseline bloods, and I'm particularly interested in his kidney function. Once all those safety nets are in place, then and only then do I dive into the detailed history and physical exam.
Excellent. A very safe and systematic start. Now, let's get to the exam. What are the classic textbook signs you're looking for?
When I examine the leg, I'm hunting for the classic 6 Ps. First, there's pain, usually severe and out of proportion. Then pallor, where the leg looks pale, almost ghostly. Pulselessness is next, which I'd confirm with a handheld Doppler. Then you have paresthesia, that pins and needles feeling. The leg will also be perishingly cold to the touch compared to the other side. And the last one, the most ominous one, is paralyzation. If the patient can't move their foot, that's a massive red flag. It tells me the ischemia is incredibly severe, and we are on the verge of losing that limb.
Okay, so we've identified the signs. Now we need to move from suspicion to a formal diagnosis and, just as importantly, classify how bad this really is. This is absolutely key for deciding what to do next.
All right, let's add some more detail to the picture. On your exam, you notice he has diminished sensation in his foot, and when you ask him to wiggle his toes, there's some mild weakness. How do you use that information to formally classify this condition and guide your next move?
So with those specific findings, sensory loss plus some motor weakness, I would use the Rutherford classification. And based on this table, this patient fits perfectly into category 2B, immediately threatened. You know, this isn't just about putting a label on it for paperwork. This classification is our roadmap. It tells us exactly how much trouble we're in and how fast we need to act.
And this is the single most important point of the classification. Rutherford's second eye is the critical threshold. It is an absolute, non-negotiable indication for urgent surgical intervention. We've passed the point where we can wait and see. The limb is immediately threatened, and every minute we delay from this point on is costing us viable tissue.
All right, the diagnosis is made, the severity is classified, and the urgency is clear. Now comes the big decision. What are we actually going to do to fix this?
So, given that you've classified this as Rutherford's second eye ischemia, what are your primary options to get the blood flowing again, and how are you going to choose between them?
Well, we really have 2 main tools in our toolbox: thrombolysis, which is clot-busting medication, and surgical embolectomy, where we physically go in and remove the clot. Now, for a Rutherford 2B case like this one, it's not much of a choice. Thrombolysis is great for less severe cases, but it's just too slow when a limb is this threatened. Surgery is the only option that gives us what we desperately need: rapid restoration of blood flow.
So, surgery it is. Now we have to shift our focus to the procedure itself, and just as importantly, to the dangers that are lurking in the post-operative period.
Okay, you're taking the patient to the operating room for a surgical embolectomy. Walk me through the key steps of the procedure. Absolutely. I'd perform a femoral embolectomy, so we'd start with an incision in the groin to expose the main artery there. After we get control of the vessel, we make a tiny cut into it. Then we pass a special tool called a Fogarty balloon catheter down the artery, past the clot, inflate the balloon, and gently pull the clot out. We know we're successful when we see good antegrade flow. That's a nice strong pulse of blood heading down the leg, and good back bleeding, which tells us that downstream pipes are open. And the final critical step before we close up is a completion angiogram. Basically an X-ray with dye to make absolutely sure we got all the clot out. The procedure goes perfectly. The pulse is back in the foot, but you are not out of the woods yet, not by a long shot. What are the 2 major limb-threatening complications you now have to be on high alert for? The first big one is called reperfusion syndrome. The best way to think about it is like a toxic dam breaking. For hours, all these nasty byproducts, potassium, myoglobin, acid, have been building up in those dying muscle cells. The second you restore blood flow, whoosh, all of that toxic sludge gets washed out into the rest of the body. It can hit the heart, causing deadly arrhythmias, and slam the kidneys into acute failure. It's a systemic crisis.
The second monster you've got to watch for is compartment syndrome. This one is really insidious. Imagine the muscles in the lower leg are packed into rigid, unyielding boxes made of fascia. After you restore blood flow, those damaged muscles swell up, but the box can't expand, so the pressure inside just skyrockets, crushing the tiny blood vessels and nerves within the muscle. And here's the terrifying part. You can have a booming pulse at the foot while the muscle inside is dying from the pressure.
So how do we catch it? Well, clinically, the hallmark is pain that's just off the charts, way more than you'd expect, especially when you passively stretch the foot. But the definitive diagnosis is to actually stick a needle connected to a pressure monitor into the muscle compartments. And there's a magic number. If that pressure is reading greater than 20 millimeters of mercury, that's it. That's your indication for an emergency fasciotomy to slice open those compartments and release the pressure. Okay, we've been through a lot here. Let's boil it all down. To pass this Viva station, and more importantly, to save your patient's limb, what are the absolute must-know high-yield takeaways?
If you remember just one thing from this whole scenario, let it be this. It's the core principle of everything we've discussed. Unnecessary delays can result in amputation. Every single minute counts. There is no room for hesitation.
So, let's run through the final checklist. Your diagnosis hinges on the 6 Ps. You use the Rutherford classification to decide how fast you need to act. And remember, IIB is your trigger for the OR. Your very first move is always anticoagulation. After the surgery, your job isn't done. You must be paranoid about reperfusion syndrome and compartment syndrome. And through it all, you have to remember that simple, powerful mantra, time is tissue. Act decisively.
Let's wrap up with one final challenge to put it all together. The operation was a success, the leg is warm, the pulse is back. But an hour later, your patient tells you they have new numbness right in that little web space between their first and second toes. What specific nerve is being compressed, and what is your immediate action? The answer? That's the deep peroneal nerve, a classic textbook sign of anterior compartment syndrome. Your immediate action is to take the patient back to the OR for an emergency fasciotomy. That's how you put all the pieces together to save a limb. Thanks for joining me for this explainer.